Rod, are you in this one? No. Oh, okay. This QTG is mainly into the cardiac and respiratory stuff. So we're going to start kind of with some simple things and work our way towards the vent as our last lecture. And then go into skills and protocols using all these. So first lecture, CHF. Basic objectives, in addition to Sam's objectives, are differentiate the types of heart failure, and we'll go through multiple different types and why you need to know difference. Pathophysiology of different types of heart failure, then you know why your drugs work or don't work, and understand treatment of CHF. And then that's when we'll go into our protocol. So you guys have the attached protocol with the slide handout. Definition of heart failure: inability of your heart to maintain sufficient perfusion for normal organ function. So can fit a whole spectrum, and it's a pretty loose definition. So there's multiple different types of heart failure. I really could have put it into about 25 or 30 different types of heart failure. Obviously, that's a little bit above what you need to know for pre-hospital, but just understanding that this is kind of a simplistic view of heart failure. And we'll go through all these, but you have high output versus low output, systolic, your contraction phase, versus diastolic, your resting phase of the heart, right and left-sided, and acute versus chronic heart failure. So systolic is basically a pump problem. Your heart, when it's contracting, can't pump enough to cause forward flow. So it's just a bad pump, not working. So this is when it's in its contracted phase of heart cycle. Most common causes are hypertension and ischemia. Kind of interesting that 10% of the population over age 65 have some component of CHF. CAD, which goes with your ischemia, ischemic cardiomyopathies, so they get enlarged hearts due to previous MIs. Valve disease. Your biggest one with systolic is going to be your aortic stenosis, trying to push against a high pressure, can't get across. And then non-ischemic cardiomyopathies, and this list is huge, but think about a viral myocarditis, affects the heart, now it can't pump well. But you can get restrictive myocarditis and all sorts of radiation-induced problems from lung cancers and other head and neck cancers. And in diastole, it's a filling problem. So if you think about your heart relaxes to fill, if it can't relax enough, you can't put much volume in it. So it's a stiff ventricle that just won't open. It needs so much pressure to open that and fill. So that, and even though we think of diastole as when your heart's relaxing, it actually requires ATP and energy to undergo that process. So it's an active process of the heart to open, and if it can't fill, then you have diastolic heart failure. So hypertension is the most common cause, and you'd think, oh, that should be a systolic problem, but it's due to long-term hypertension. You get this big enlarged heart, it's working. It needs to get thicker and thicker and bigger to pump against all that peripheral resistance of the high blood pressure. It can only do that so long, and then it can't relax because it's so big and thickened it can't fill. So it's almost a systolic problem causes the diastolic, but hypertension here in Western world. Aortic stenosis, scarring after AMI, you have a piece of your heart that's dead, doesn't move. Through diabetes, you get a whole change in the way that heart muscle works due to the insulin resistance, the high glucose, and it's called glycosylation of the heart, but basically it's just a remodeling of the heart. And ischemia, if it's true just ischemia and not infarct, it can reverse after you treat the area of ischemia. So you can see this in an acute MI. If you fix it before they truly have dead heart, you'll reverse that. These patients can still have a normal EF because it looks like they're emptying everything they have. They may empty 55%, but they didn't relax enough to fill much. So you have such a small stroke volume, can't pump it out. And that's the get a big, strong heart to overcome and stretches too much and fails. So that's the whole kind of principle of how you get diastolic heart failure. So left versus right is kind of one of the biggest things you guys are looking at when you're in the field is this left-sided heart failure, is this right, or is it both? In reality, it's almost always going to be both. But left-sided heart failure is a failure of your left ventricle. So you'd get decreased perfusion. That means left-sided heart is not pumping out to the rest of the body. So initial symptoms are going to include fatigue. You're just tired. It's that patient that says, last 2 weeks, every time I walk up the steps, I'm tired, short of breath, and I got to sit down. And just walking across my house, I'm tired. So they'll complain of fatigue. Very rarely are they going to call 911 for fatigue, but you might get the nursing home patient that just says they're really tired and they're sleeping a lot. Renal dysfunction, you're not perfusing your kidneys, so they can go into renal failure from decreased output from the heart. Hypotension, not pushing enough blood out. And dyspnea, because fluid's backing up into the lungs. And they'll complain of shortness of breath. On your exam, very rarely can you actually hear this in the field. Very rarely is it quiet enough for me to hear in the ER. But that third heart sound that you'll hear, and your PMI. So that's your point of maximal impulse. Your heart should be kind of sitting down about right here. In CHF, big enlarged heart, be displaced laterally, inferiorly, just because that ventricle is getting much bigger. These are the patients that have that big heart on a chest x-ray. So that's your left-sided. They're tired, they're short of breath, they don't have peripheral edema. Right-sided heart failure means it's not returning back to the right side of the heart and pumping out. So those are the ones that have the pitting, weeping legs, JVD, hemoptysis. You can see that in the left sometimes too because it's backing up, but because PEs can cause right-sided heart failure, you can often see hemoptysis in that. And hepatic congestion, just because it's not pumping out from the periphery and it's all lodged in the liver. So often these patients will have elevated LFTs. And the most common cause of right-sided heart failure, left-sided heart failure for chronic or subacute or recurrent. We'll talk about the sudden acute right heart failure at the end, but if you have left-sided heart failure, progresses, not treated well, exacerbates, that's when you get right-sided heart failure. So you can have both on the patient you pick up that's got pitting edema, they're short of breath, they're coughing up frothy pink sputum, got JVD, they're probably both. So to understand your treatment of CHF, you have to go back to our basic physiology and the Frank-Starling curve. So if you look at your three different arches, so this is all of us sitting here with normal stroke volume, we have normal ventricles, we're pumping end, and this is your end diastolic pressure. So when you're relaxing and filling completely, you're get a stress test and you get an inotrope, or you're running a race, or you're running a code, you'll have increased contractility. So you get more output because of increased ability of that heart to contract. In CHF, they can't contract. They get pulmonary congestion because they keep increasing their end diastolic pressure, but as they do that, they're not pumping out, so their stroke volume cannot increase to the same way that a normal heart can. So the whole goal, is to try and push your patient on your heart failure back this direction by decreasing their left ventricular end diastolic pressure so that they can have more stroke volume. Because eventually, it'll just drop off and you plummet on your heart failure patient. We'll just kind of plummet down here, and you'll be back down here, and that's when you get those flash pulmonary edema patients. So high output cardiac failure. You're not going to see this a lot, but you could see these on some of our transfer patients, more critical care patients. So these are high output. They're pumping fast and hard for a long time. So most common kind of causes thyrotoxicosis. So that thyroid's in overdrive, and your heart rate's sitting at 140 all the time. These are those kind of guys that get the exophthalmos with the big eyes. There's hair gets all kind of thin and crazy in there, like it's a whole endocrine process. So they are completely tachycardic, sleeping, awake, active, resting. Chronic anemia, if you think about it, you don't have enough hemoglobin to feed your body, so you're pumping harder and faster, trying to get enough oxygen delivered to your cells because you just don't have the hemoglobin. And pregnancy, it's important to increase the volume, and so they're put the significant increase in your output while you end of pregnancy. So you arrive and evaluate a patient with CHF. Get in your exam and your history. You want to know, is this new? Did this happen suddenly? Did it gradually over the last few weeks? Have they had a history of it? And then your exam. They have JVD. Do they have rales? Decreased breath sounds? Are they working to breathe? Do they have pitting edema? Get an EKG. So we have a whole EKG lecture, but we'll go through. But the most common things you'll see are LVH, because they've been making that ventricle get bigger and bigger and bigger. So you'll see findings of LVH on your X-ray or on your EKG. AFib is just due to changes the electrical activity of the heart, and right bundle branch blocks as it changes that axis. And then the ER, or if you're transferring a patient out of here, you look at your labs. Your BNP is kind of that known marker that changes. It is excreted by the myocardium when it's under increased stretch, so that's when we see the BNP go up. In chronic heart failure, though, it can either just chronically stay because it's always so stretched. So a BNP of 1,200 may be where they live, and that may be chronic always. Or you can have a patient in acute pulmonary edema, and there's just not enough stretch to the myocardium yet on your labs because it's acute, and your BNP is 200. It doesn't really mean a lot. So it's a good lab to differentiate for those of us trying to decide, is this their CHF, is this their COPD? Otherwise, it's not a good utilization that it was when it first kind of came out, and we thought it was the end-all be-all to determine CHF versus COPD. So what do you see on this X-ray? Anybody? What do you think of? So they're fluffy. My pointer. So kind of fluffy out in here. What do you think of this? So that's about twice the size your cardiac silhouette should be. So big, huge heart here. Loss kind of your lung margins down at the bottom, so little pleural effusions. And then all these increased markings that we look for. I mean, there's fluid in there, fluid in the fissures. So this patient has, whether it's chronic or acute, you can't really tell without seeing the patient, but definitely cardiomegaly and volume overload. So treatment in the hospital, in the field, and at home. When you get there, IV oxygen monitor. And like we talked about before, through so many things, as your oxygen, if they're satting 99%, they don't need oxygen. They're at 88%, they need oxygen. Your goal is to get them somewhere around 95% if they're not a COPDer and they're just CHF. But we don't want to aim for 99, 100% giving additional oxygen. If that's where they're sitting, that's great. But if you think about it, if you have a pulse ox of 90 or 100%, their PaO2 could really be 400. And that's not good for patients to have high levels of PaO2s. You get, and we'll go through that in one of our, I think, the vent lecture, but you get a lot of questionable free radicals, and patients do worse in many ways when you give them high oxygen unnecessarily. So you reduce your preload with nitrates. That's why we give the nitro. And we talked about that Frank-Starling curve. You want to decrease your left ventricular end diastolic volume, let that shift back to the left, and allows for better contraction of your heart, more output, increased stroke volume. BiPAP or CPAP. Most time we're doing BiPAP here, but obviously you guys have CPAP in the field. So the biggest thing is it just decreases their work of breathing. It uses less energy, so it's more rest on the diaphragm. The other process is it increases your thoracic pressure. So increased pressure here decreases that venous return. Again, changes your left ventricular and diastolic volume, pushes that Frank-Starling curve to the left. So that's why CPAP works. And then we talk about afterload reductions with ACE inhibitors, nipride. Lasix is still in our protocol. If you have about a 5-minute transport time, you're not going to see much improvement with it. You got 20 minutes to an hour before you're going to get much of that. And really the way Lasix works is it's just working in the kidneys to decrease, it's diuretic. It gets rid of volume. So heart has less to push against if it's got less volume in there. So works on volume overload patients. If they're not volume overloaded, Lasix isn't really going to help you. Yes? Yeah, I mean, you want to really be cautious that you're not giving this to a septic patient and decreasing their volume, because we're going to be trying to fluid resuscitate them, even if they're CHF chronic patients when they come in with sepsis. So if they've got a fever, purulent sputum, they've been vomiting, and they kind of have all those other findings in addition to their CHF, sepsis, pneumonia, infection somewhere, you really, really want to not go down that Lasix pathway, because then we're just getting more volume. I mean, the theory is in sepsis, you're giving them 3 liters minimum of fluid over the 6 hours they get here. So adding Lasix really kind of puts us more behind the 8 ball with that. So this is kind of only for that straightforward flash pulmonary edema, and you're not 5 minutes from the hospital. You're up in Hamilton County, and you're coming with a long transport, and you can start to get some relief. But giving it 5 minutes before you get here really isn't going to help them get the nitro on board. And a big thing that we talked about before we get into chronic heart failure is you can give nitro with CPAP on. So best way is first give that first dose before you get the mask on them. Getting your CPAP all set up, you know their flash pulmonary edema, get that 1 nitro in, because you can stack 3 nitros in flash pulmonary edema. I mean, that's going to give them the most relief, decrease their stretch, and improve their breathing, is nitro, nitro, nitro. So get a nitro in, get them on the CPAP, and disconnect enough to get that 2nd or 3rd nitro, but often you should be able to get 2 nitros in before you get them on the CPAP, just because the nitro is the easy thing to do versus getting the CPAP all hooked up and situated. So don't delay your nitro because you think you need CPAP. Get the nitro on board as long as their systolic's not 80 and they can handle it. But most of these guys are going to be hypertensive, sweaty, big pitting edema, dyspneic, and the nitro. I have seen patients go from, I think I'm going to tube them, and 20 minutes later after 3 nitros and BiPAP, they're ready for the mask to come off and they're talking to me. So nitro can really take off that preload.
What do you think about
I mean, when you think about it, think about what your dose is with a nitro spray versus your IV. You got to get a lot of IV in versus 1 spray. So unless they're hypotensive, which then you shouldn't be doing it anyway, much faster to give. I don't think I've ever given, unless I'm doing it for blood pressure control later, because they're more of a hypertensive urgency or emergency, I don't ever start an IV drip of nitro for treatment. I give them the sprays or the tablets. And you guys may have given 3, and I might give 2 more if they still got a blood pressure of 180 when they come in and they can tolerate it. So drip really is just kind of like spitting compared to giving them that whole dose. So chronic heart failure. Steve wanted me to put a picture of Stella up here for all you guys that remember transporting her. She was the picture of chronic heart failure. 65% 5-year mortality in chronic heart failure. So these patients don't do well, higher survival in a lot of cancers than CHF. And the last one that you guys will see kind of acutely is the cor pulmonale. And this is seen in your COPDers, your pulmonary fibrosis, pulmonary hypertension patients. So that right side is pushing against a very high pulmonary artery pressure. So they get right ventricular strain, get T-wave inversions in V1 through V3. You'll see the right bundle branch blocks and right axis deviations. So your COPD and your pulmonary diseases are going to be your most common causes of chronic cor pulmonale. Your acute, so you get a 42-year-old woman. She's sudden onset, of kind of all your right-sided heart failure. She's got hemoptysis and dyspnea. PE is going to be one of your number one thoughts if you don't see an MI on her 12 lead. Is you got this big clot. If you have a proximal clot in that pulmonary artery, or one of those first branches, that heart's trying to push against all this pressure, and they can go into acute right-sided heart failure and show all these EKG changes with a big PE. Little tiny PE, you're probably not going to see much change. One other thing is, remember, a lot of these patients are now on all of the Viagra, Cialis, and they're on them chronically, even women, for pulmonary hypertension. So make sure you look at their med list on these patients. You don't want to be loading them with nitro, and they're on daily doses, not the one-time ED doses, but daily doses of all of those drugs. So you want to be looking at their med list, asking if they take anything specific for their pulmonary hypertension. A lady just this last weekend that came in with kind of chest pain and was on daily Viagra for her pulmonary hypertension. So in addition to asking all the males if they're on it for their ED, ask if any of the women are on it. And you'll see congenital kids now. I mean, we have so many more kids surviving all their congenital heart disease. There'll be teenagers and young adults who are on those meds chronically for their bad pulmonary hypertension, trying to bridge them before more valve replacements and transplants. So just a word of caution. So that's CHF. Anybody have thoughts, questions? We'll go through our protocol too.
Yeah, I guess we might cover it. But, you kind of run into, I know I have, got that person with COPD, CHF, and just kind of being able to figure out what's what, going down the COPD protocol versus the
CHF.
and just,
And
it's kind of a tough question to maybe answer on the spot without having to.
right, I mean, you're looking at each patient, but there's times I can't tell either because I've got both, and maybe it's a mixture of both. One pushed him over the edge to the other. What you looking for, Sam? Oh, and so often if they're not wheezing, a nab is really not your choice. You don't want to give nabs if they're not wheezing, but if they're wheezing and they look like a COPDer as well, doing your nitro and a neb through your CPAP is reasonable in the initial because you don't know what you have. And then we get the luxury of looking through their records, getting a nice EKG, looking at their chest x-ray, and more time to figure it out. But that patient walks in the front door, I might give them a neb, give them a sublingual nitro, get a 12 lead, and entertain putting them on BiPAP. Right. And that's why in isolated left-sided, it's going to be hard to tell if they've got underlying COPD, and then they kind of have a left-sided heart failure because they're not going to have that pitting edema, the JVD. So you just have to go with your best instinct in your gut and go one, and you're not going to be wrong unless you're giving a neb to a non-wheezing 98% SAT patient. Then you're not really gaining anything. Does that make sense? So kind of just looking through our protocols, kind of same thing I went through. Get your 12 lead. For mild distress, consider your nitro sublingual. You can consider your Lasix depending on your transport time and what they look like and their blood pressure. And morphine will also cause some vasodilation and works similar to your nitro, just clearly not the same severity of that. And then we talk about adding on the nitro drip if you've already done your 3 nitros, getting improvement but not enough, then you can start the drip. But that's not what you're going to go to before your first 3 doses. And then obviously RSI them if they're that distressed. And there's the generics at the bottom of our protocol of all those drugs that you need to ask about if you see generics, because a lot of those, the insurance pays for those in pulmonary hypertension if they're on the generics. Any other CHF questions, thoughts, comments? You guys are quiet. Okay. You guys can take a couple minute stretch and then we'll get set up for the next one.